Hello everyone. In this class, we'll learn about heart rate and arterial pulse. The learning objectives of this class would be give normal range of heart rate and physiological variation of heart rate, understand the mechanisms of regulation of heart rate, appreciate the graph of arterial pulse tracing, list the causes of bradycardia and tachycardia, name the causes of common abnormal pulses and understand their physiological basis. The normal heart rate is around 60 to 100 per minute in adults. Heart rate less than 60 per minute is called as bradycardia and above 100 per minute is called as tachycardia. Normally heart rate is more in infants and children and less in geriatric age group. Heart rate reflects the rate of discharge of cardiac pacemaker. As SI node is the natural primary pacemaker, heart rate is the rate of discharge of SI node. There can be physiological variation. Heart rate is more in infants and children. After the age of 60, heart rate decreases. Heart rate is comparatively less in females due to their relatively high parasympathetic tone and less basal metabolism. There can be diurnal variation. Heart rate is more in the day, especially in the afternoon, and less in the night, especially during sleep. This difference is due to the less physical activity and sympathetic discharge in the night and due to the low levels of stress in sleep than in awakened state. Increasing the body temperature increases the heart rate and decreasing the body temperature decreases the heart rate. The heart rate is more during inspiration and less during expiration, that is called as sinus arrhythmia. This is merely uh, due to alteration of the vagal activity, which is more in expiration and less in inspiration. Environmental temperature. Heart rate is more in summer and less in winter. Food intake increases heart rate by increasing body metabolism. Change in the posture from supine to standing increases the heart rate due to the increased stimulation of baroreceptors. Heart rate increases in exercise due to sympathetic stimulation. Heart rate may even increase before starting exercise due to the psychological effects that acts through the limbic system. Coming to regulation of the heart rate, there can be neural mechanisms in that autonomic control. So in that parasympathetic control, parasympathetic fibers supplying the heart originate in the nucleus tractus solitarius, dorsal motor nucleus of vagus, and nucleus ambiguous in the medulla. Right vagus supplies the SA node and the left vagus nerve supplies to the AV node. Stimulation of vagus nerves stimulates or results in decrease in the heart rate. This is due to the secretion of acetylcholine at the vagal nerve endings that suppresses SA node. However, cholinesterase, the enzyme that hydrolyzes the acetylcholine, is present in higher concentration in the nodal tissue. Sympathetic control. Sympathetic fibers supplying pacemaker tissue originate from the lower two cervical and upper six thoracic segments of spinal cord. The stimulation of the sympathetic fibers increases the heart rate. The effect of sympathetic stimulation persists longer as there is no specific enzyme to degrade norepinephrine, which is released at the sympathetic nerve endings. Norepinephrine is mostly taken up by the nerve terminals and the remaining amount is slowly absorbed into the circulation. Moreover, the effect of norepinephrine is mediated by adenyl cyclase system, which takes a longer time to exert its effect. Then there can be reflex control, baroreceptor reflex. Baroreceptors located in the carotid sinus and aortic arch and are stimulated when blood pressure rises, which in turn stimulates the nucleus tractus solitarius in the medulla via 9th and 10th cranial nerves. Nucleus tractus solitarius inhibits the vasomotor center, and inhibition of vasomotor center decreases sympathetic activity via bulbospinal pathway. Decreased sympathetic discharge decreases heart rate. Stimulation of NTS also directly stimulates the vagus nerve that causes bradycardia. Chemoreceptor reflex. Chemoreceptors are stimulated by change in the chemical composition of blood as occurs in hypoxia, hypercapnia, and acidosis. Activation of chemoreceptors primarily produces bradycardia, but that heart rate may remain unchanged or even slightly increased by secondary effects. Bainbridge reflex, rapid infusion of saline or blood increases heart rate if the initial heart rate is less. The receptors are present in the atria at the veno-atrial junction and are known as tachycardia producing receptors (TPR). This reflex accounts for tachycardia produced following saline infusion or blood transfusion. The effect of Bainbridge reflex on heart is more observable if the initial heart rate is less. This reflex competes with the baroreceptor reflex and tries to increase the heart rate. Cushing's reflex is activated in gross hypovolemia and hypotension that decreases the blood flow to the vasomotor centers in the medulla. Direct stimulation of vasomotor center produces vasoconstriction and tachycardia, but the consequent increase in the pressure stimulates the baroreceptor that finally results in bradycardia. Control by higher centers, stimulation of the motor cortex, frontal lobe, thalamus increases heart rate. Increasing the heart rate in emotional states, anxiety, and excitement is due to the stimulation of limbic system. There can be humoral control mechanisms like thyroxine and catecholamines increase the heart rate, these hormones. Chemicals, hypoxia increases the heart rate, which is partly mediated by release of catecholamines from adrenal medulla, and hypercapnia and acidosis decrease heart rate. Coming to arterial pulse. The arterial pulse is defined as a rhythmic expansion of the arterial wall due to the transmission of the pressure wave along the walls of the artery that are produced during each systole of the heart. Normally the pulse rate is same as heart rate, thus normal pulse is also around 60 to 100 per minute. The deficit between pulse rate and the heart rate is called as pulse deficit. Pulse rate is more than 100 is called as tachycardia, less than 60 is called as bradycardia. Normally heart rate is more in children, less in elderly. So this is how a pulse can be recorded during the contraction and during the relaxation phase. So during contraction it is called as percussion wave, and during relaxation you have a diacrotic notch. Normal pulse tracing. Arterial pulse tracing shows two waves on one notch. The waves are percussion wave and also called as a tidal wave, and a diacrotic wave, and the notch is diacrotic notch. Percussion wave occurs due to the ejection of blood during the ventricular systole. Diacrotic wave occurs due to the rebound of blood against the closed aortic wall during diastole. Diacrotic notch represents closure of aortic wall. Variation in the heart rate, as we discussed, causes for tachycardia physiological are exercise after eating, anger, emotion and excitement. It is high in case of infants and children. It is increased in pregnancy. It is increased when temperature is high, environmental temperature is high. Some of the pathological causes are fever, anemia, thyrotoxicosis, beriberi, Paget's disease, arteriovenous fistula, heart failure, paroxysmal atrial tachycardia, ventricular or supraventricular tachycardia. Other tachyarrhythmias increase the heart rate. Some of the causes of bradycardia are physiological. It is low in case of athletes during fear, grief, very old age. In yogis, the heart rate is less. Some of the pathological causes are myxedema, increased intracranial pressures, example brain tumors, obstructive jaundice, different types of heart block, drugs, example digitalis, they decrease the heart rate. Some of the abnormal pulses are anacrotic pulse. It is also called as anadiacrotic pulse, which means two upbeats. A secondary wave occurs in the upstroke of the pulse. It is commonly found in aortic stenosis. The upstroke is slow and sloping. Diacrotic pulse. It is also called as twice beating pulse. The diacrotic wave is prominent and gives the feeling of two beats. It is commonly seen in febrile states, especially in typhoid fever. Water hammer pulse. This is also called as collapsing pulse or Corrigan's pulse. It is typically seen in aortic regurgitation. The collapsing pulse is characterized by rapid upstroke, that is ascent, and rapid downstroke, that is descent of the pulse wave. The rapid upstroke is due to the greatly increased stroke volume, and rapid descent is due to the collapse of pulse. The collapse of the pulse occurs due to the two factors: the diastolic runoff of the blood into the ventricle and rapid runoff of blood into the periphery because of the decreased systemic vascular resistance. Therefore, pulse pressure is very high, maybe as high as 100 mm of Hg. Some of the causes for collapsing pulse are aortic incompetence, patent ductus arteriosus, arteriovenous fistula, ventricular septal defect, and hyperkinetic circulatory states like thyrotoxicosis and severe anemia. The collapsing pulse is a steep rising, forceful, and high amplitude percussion wave. The steep rise of the ascending limb of the pulse wave is due to the increased end diastolic volume of the left ventricle, as during diastole, in addition to the ventricular filling from the left atrium, the filling also occurs from the incompetent aortic wall. This increases the total end diastolic volume, which increases the force of contraction of the left ventricle during systole by Frank-Starling's mechanism. Thus, steep rise occurs in the percussion wave during systole. The steep fall of the descending limb of the pulse wave is due to two factors. One is diastolic runoff of blood into the left ventricle and rapid runoff of blood into the periphery because of the decreased systemic vascular resistance. Pulsus bisferens. Pulsus bisferens is a combination of low rising pulse, that is anacrotic pulse, and collapsing pulse, which is seen in aortic stenosis. Pulsus paradoxus. Pulsus paradoxus. Amplitude of pulse decreases in inspiration and increases in expiration. In pulsus paradoxus, in inspiration, the volume of the pulse grossly decreased or may be even absent in severe cases. Some of the common causes for pulsus paradoxus are constrictive pericarditis and pericardial effusion. And less common causes are emphysema, asthma, massive pleural effusion, a mass in the thorax, advanced right ventricular failure. During inspiration, the intrathoracic pressure becomes more negative. Pooling of the blood occurs in the pulmonary vascular bed, which decreases venous return to the left atrium. Thus, left atrial filling decreases. That in turn decreases the left ventricular stroke volume. Therefore, volume of the pulse decreases in inspiration. During inspiration, the intrapericardial pressure increases due to the traction from the attachments put on the pericardium. So this decreases the venous return to the heart and results in low stroke volume. So this is more accentuated in pericardial effusion and constrictive pericarditis. In constrictive pericarditis and pericardial effusion, the filling of the atria and ventricles decrease due to the restriction to the expansion of the heart chambers. The limitation of the diastolic filling of the right atrium and the right ventricle during inspiration results in lowering of the left ventricular stroke volume. In advanced stages of ventricular failure, increase in the lung volume in inspiration accommodates more blood than the normal due to the much decreased pulmonary vascular resistance. There is a decreased right ventricular output. These two factors decrease venous return to the left atrium, that in turn decreases the left ventricular stroke volume. In bronchial asthma, increased respiratory effort makes intrathoracic pressure more negative during inspiration. Hence, there is more pooling of the blood in the pulmonary veins that results in decreased ventricular stroke volume. Pulsus alternans. The pulse is regular, but the alternating beats are strong and weak. A difference of 5 to 20 mm Hg in systolic pressure is marked between two alternate beats. Some of the causes are left ventricular failure and toxic carditis. The physiological basis is in left ventricular failure due to the decreased myocardial contractility, stroke volume is decreased. This results in low volume pulse. Due to the inadequate ejection of the blood during systole, the end diastolic volume of the left ventricle increases. Therefore, the end diastolic volume increases before the onset of next ventricular contraction, and this increases the force of contraction of the ventricle in the next beat by Frank-Starling mechanism. Consequently, second beat becomes stronger. Likewise, the strong and weak beats alternate. So these are some of the example of the anacrotic pulse, that diacrotic pulse, the collapsing pulse, and so this is pulsus bisferens. That is, you can see during inspiration, the volume is the pulse is going to decrease, and during expiration, the pulse is going to be exaggerated. And this is pulsus alternans, which is usually going to occur because of the left ventricular failure. This is in brief about the heart rate and the arterial pulse. Thank you.